you, and we'll go through as many slides as we can, but I don't want to go too quickly. So let me just share. And so it's plain old boring. I put no pizzazz in it because people often get distracted by the colorful, pretty slides. So this is a super boring slide or a slide set. So we're going to go through a little bit about the exam first. So this is important. This comes directly from CNA. And so guess what? The exam you're writing is the longest exam of all of them. Great. So 150 questions is the average. Yours will be around 165. So what do the questions look like? Almost 70% of them are independent questions. They stand alone. And then closer to 30% are case-based. So pay attention. It'll say questions 7 through 11 pertain to the following case study. And so make sure that you're not into question 14 and 15 still looking back at the previous case. So make sure that you know what questions go with the case. Simple knowledge questions make up a small part of the exam, but application and critical thinking questions are the majority of the exam. And so what an application question is you take knowledge and you apply it to your practice. But what a critical thinking question is one that you take knowledge, you apply that knowledge, and then you determine what are the consequences of that application. And so critical thinking questions are always the tough ones that we say, oh my God, all of the answers could be right, but what is the best one? You remember those ones in nursing school that we all hated? Those are critical thinking questions. The company that invigilates and writes this exam for us with CCCN help is very adamant that we have only one right answer, and the others are distractors. So if you know your material, you'll be able to pick out the answer easily. And what I've always found beneficial with multiple choice questions is I cover up the answers and I read the question and I try and formulate the answer in my mind before I look at what my options are. And that way, if you know the material, you'll know the answer very quickly. And then if you don't know the answer, you have to do an elimination of, well, why couldn't it be this? Why couldn't it be this? And so you rule out the 3 that you think are wrong and then the potential one that you think is right. So how are the questions kind of divided? And this is important for your focus of study. So ischemic heart disease is going to make up to 25% of your questions. The frustrating thing for many of us is that almost 20% are health promotion, health prevention. But I'll be very honest, I'm not a cardiac rehab nurse, nor do I have an interest in that type of nursing. I'm glad that there are nurses who love that. But I found all of the questions about cardiac rehab, health promotion, very common sense. They would be the advice that I would give my coronary care patient upon discharge. So I found them very common sense questions. It was all about motivating the patient. It was all about allowing him or her to have choices. And so you're never going to pick the response that says, the nurse will tell the patient. You don't, you negotiate, you motivate the patient to make good decisions. And so, for example, when you're teaching about heart function or lack thereof, heart failure, you don't go in with a very authoritarian attitude. You go in and say, so, sir, you like to eat Chinese food 4 days a week. So we know that sodium is very high in what we call Canadianized Chinese food. So I understand that's an important part of your life. You enjoy it very much. However, the sodium load is too much for your heart function at this time. How do you think you could manage reducing the amount of sodium that you take in? And so there's lots of options. There's options to decrease the number of intakes a week. Maybe make it a special celebration at the end of Tuesday or the end of Friday. Maybe that's a day that your Lasix dose gets increased from 60 to 80. Or maybe you are a great cook and you look at alternatives to sodium load. So look at the response that gives the patient autonomy, gives them decision-making ability, because they will be much more successful. So that's what I found all of the health promotion strategy questions were on there. Heart failure, we prefer to call it heart function now, but can be up to 15% of the questions. Cardiac surgery intervention can be up to 15%. PCI is probably weighted closer to 18%, and the surgery component closer to the 5%. And the reason for that is not every center in Canada does cardiac surgery. And so the questions about surgery are pretty general. PCI, people need to know how to care for patients pre-PCI and post-PCI, but there's not a whole lot of cath lab questions in there. So you're not going to have to know techniques or when an IVUS would be used, or like a flow reserve wires and things like that, because it's a general nursing exam. Cardiac arrhythmias. The tough thing about this exam is there's not much opportunity for graphics. And we have asked the yardstick, the people who developed the exam, is there any way we want to put in 12 lead ECGs? We want to put in rhythm strips. There's super limited abilities with the software that they're using. So most of the questions will be describing the rhythm, which is actually more of an application question. Knowledge question, you look at VFib and you say, oh, well, that's easy, VFib. But pay attention to how they describe the arrhythmia. They might also add in some hemodynamic component to you to help you discern whether the patient's stable or unstable. Valvular disease, I don't remember a huge amount of questions about valvular disease. I do remember a few about vascular disease. And you know what they say about the questions you remember are usually the ones that you struggled with. I worked surgical intensive care unit for 20 years. I cared for vascular patients on a daily basis. But I did find that there were quite a few questions about claudication, which I didn't expect. And so there is a couple of articles that I sent you. One is quite a lengthy one about vascular disease. Skim through it because not all of it applies. Skim through it and spend some time on claudication and intermittent claudication. The last three competencies are minimal. So inflammatory disease, psychosocial needs, they can almost build into any question. A lot of the health promotion ones were psychosocial needs, and cardiogenic shock. But there is a mandate to have some questions in every exam. So the cardiovascular exam, the critical care exam, the oncology exam, about assisted dying. And they would not be specific questions about how it would be done. It would be more like allowing the patient and family to participate as equal partners, to allow the person the autonomy to make the decisions and how and when it could and should happen. And then cardiogenic shock, if that's your biggest fear, I don't want you to fear, because there are not very many questions on cardiogenic shock. So the majority up here in the ischemic heart disease decrease as we go down this list. So those are your competencies, and those are the weeks of readings that you've done. So try not to change your answers. And I know that's funny. Everybody gives you that and everybody goes back and changes an answer. But they work really hard at not letting later questions give away the answer to previous questions. So you're never going to say like 10 questions later, oh, I got to go back and change this question because that's what they meant. So the standalone questions don't interlink, and they work really hard at that. Pay attention to any cases and make sure that you know what questions cover the case. And I've never written a computerized exam, because when I wrote both my cardiovascular and my critical care, it was paper and we could bring a highlighter. And I always found it important to highlight the important things in a question. And so let's go through this next question. And I'm going to tell you what I think is important here. So I'm going to read through it. So a 78-year-old man is admitted with a diagnosis of non-STEMI following an episode of chest pain that occurred while watching The Price is Right. He has a past medical history of chronic obstructive pulmonary disease, angina. He's had a cabbage ×5 15 years ago. He tells the nurse that he feels bad taking his metoprolol, and also known as a beta blocker, and he has stopped taking it 2 weeks ago. So what I think is important in here, so he's admitted with a non-STEMI. So I would highlight non-STEMI. And why did I bother putting an episode of chest pain while watching TV? Why is that important?
Because he's at rest?
Absolutely, because he's at rest. So this is pain that occurred at rest. Therefore, he's either unstable angina or a non-STEMI. They've told me he's a non-STEMI, but pain that occurs at rest is important to note. So he does have COPD, obviously angina. Cabbage ×5, okay, so he had significant number of bypasses. But I think the important thing here is 15 years ago, because the life of a graft is 10 to 15 years. And so what are we looking at here? It'd be interesting to see his calf. And so there's not a whole lot of information in this little scenario, but what I have determined, he's a non-STEMI. I'm surprised that he doesn't have diabetes. Usually non-STEMIs are older patients, they have more comorbidities. So there's lots of diabetic patients walking around that don't know they're diabetic. He had pain at rest. He's had a previous cabbage, and he stopped taking his metoprolol 2 weeks ago. That's significant. So I need to investigate why he feels bad. Like, what were his symptoms? And it's unfortunate, and this might appeal to Emily because she's done her thesis work on sexercise. Many men stop taking metoprolol because of their inability to have an erection. But the 78-year-old man who's being interviewed by the 25-year-old RN is not going to disclose that. He's probably more likely to disclose it to me, the 56-year-old RN, because I'm old and he doesn't really care. So there's a lot of information that's hidden in here. And so it helps you to highlight what you think is important. And so I found that cabbage 15 years ago was important because maybe he has significant coronary artery disease again. So not every question you will need to do this, but definitely your cases. Just use the highlighter and there is a highlighter in the software that you use, and just yellow highlight, whatever color makes you feel happy, to help you kind of focus in on that's what's happening with this patient. Okay, so let's get into some things. So cardiac assessment. When you think about what is unique to a cardiovascular nurse, we really have claimed ownership of heart sounds. So expect to have some questions. Whenever you hear somebody speak of a cardiovascular nurse, they'll be like, oh, well, yeah, she's used to listening to heart sounds. It might be an assumption, but it is an assumption that has been made by CNA. And so you should expect some questions. So just a quick, and this should likely be a review for most of you. You're 8 to man, or some people say all people eat toast with marmalade. I don't know how you want to remember it. Or aortic, pulmonic, Erb's point, tricuspid, and mitral. So know where these locations are on your chest, but also where you're going to hear your S1 the loudest. So in your mitral area, when you place your stethoscope here, you're going to hear lub, dub, lub, dub. And when you put your stethoscope up here and you're using the diaphragm, because the diaphragm gives you best look or best sound of high-pitched sounds, and that's what normal heart sounds are, high-pitched. So when I listen in my aortic area, I will hear lub, dub, lub, dub. My second heart sound will be loudest in my aortic area. So whenever I'm in a hurry and I don't have time to auscultate all 5 positions with both my diaphragm and the bell of my stethoscope, then I usually will use both my bell and my diaphragm in the aortic and the mitral positions. If I'm in a hurry, I leave out my pulmonic, Erb's point, and tricuspid. Now, in a perfect world, you would do all 5 points using the diaphragm first and then the bell of your stethoscope. So when we're talking about systole, it is the space of time between your lub and your dub. And this is helpful when we are listening to murmurs. So lub swish dub would be a systolic murmur. But if I heard lub dub swish, I would be listening to a diastolic murmur. So in a perfect world, when you're listening to heart sounds, your patient's heart rate is 45. In a perfect world. How often does that happen? Well, if they're well beta blocked and they're getting ready to go home, probably so. We don't usually ask questions about the 45-year-old who's getting ready, or the patient with heart rate of 45 who's ready to go home. It's very difficult to discern between systole and diastole when your patient's heart rate is closer to 100, or almost impossible when it's over 100. And so they often say that S1 correlates with your carotid pulse. And I've read that in textbooks, and I've tried to apply that to my practice, and I'm still not bright enough to be able to listen and feel at the same time and still discern which is systole and which is diastole. So much easier to determine in a patient whose heart rate is slower. So diastole occurs between S2 and the next S1. It is the longer portion of our cardiac cycle, so it accounts for about 2/3 of our cardiac cycle. And I always say there's two four-letter F words that happen in diastole, and I'm allowed to say them in a recorded session. So when you think about diastole, what happens to the ventricles and what happens to the myocardium? Two four-letter F words that occur in diastole.
Fill and feed.
Fill and feed. Absolutely. My ventricles fill during diastole. So the better fill I get, the better stretch, the better contraction. The better feed is the more I supply my myocardium with oxygen, the better it behaves. So diastole is an important part of the cardiac cycle, and filling and feeding occur. So our normal heart sounds, S1 and S2. So S1, closure of my mitral and tricuspid valve. It's heard loudest in the mitral area, so that's a 5th intercostal space. Why do I have? It shouldn't say left sternal border, it should say mid-clavicular line. So if you can make that correction, sorry about that. So my mitral area is mid-clavicular line. Women are more difficult than men. Obviously, breast tissue gets in the way. So men are easy, women are a little more challenging. So S2, closure of our aortic and pulmonic valves. Again, both of these normal heart sounds are heard best with the diaphragm. So our abnormal heart sounds are S3 and S4, and they are low pitched. So that means they are best heard with which part of the stethoscope, the diaphragm or the bell?
What'd you ask? The bell.
Absolutely, the bell. So S3 and S4 are extra heart sounds that are best heard with the bell of the diaphragm. They are diastolic sounds. So they both happen after the dub of your lub dub. The difference is where they are located in diastole. And S3 and S4 are sometimes difficult to differentiate between, but you have to know a little bit about your patient. So I know this is kind of a dumb little picture here of beer pong. It looks like pretty watered down beer, but I always think of an S3 as a ventricle that is overfilled, and now the mitral valve is open and the atrium is dumping new blood into this overfilled ventricle. And it makes kind of a sloshing sound. So think about this pong ball as the blood coming from the atria. And the fluid that's in this glass or cup is the overstated volume in the left ventricle. And when it plops down, it makes a sloshing sound. And you will hear it in very early diastole. So you'll hear lub dub ta, lub dub ta, lub dub ta. It is a lower sounding or lower pitched sound. And so you best hear it with the diaphragm, or sorry, with the bell in the mitral area. But it happens immediately after S2. So it's an early diastolic sound. So in the guy whose heart rate's 45, that's wonderful. And a guy whose heart rate's 110, pretty difficult to hear. But S3 is often associated with crackles in the lungs. And why would that be? Why would somebody with an S3 also have crackles in their lungs?
Because the ventricle is overfilled, so it spills. It backs
Yeah,
up.
it backs up. So it backs up into my left atrium. I have no valves coming into my heart. So those 4 pulmonary veins get backfilled. And then that pushes over into my alveoli and I develop crackles. So an S3 and crackles in the lungs kind of go together and are indicative of volume overload. So the way I used to learn heart sounds was I would see what the physician had written in the chart. And if he or she had written S3, then I would say, oh, Buddy's got an S3. I'm going to go in that room and listen to what that sounds like. And then an S4. An S4 is caused by atrial contraction into a stiff ventricle. And patients who have a stiff ventricle are those that have a new myocardial infarction and have a big scar, especially anterior myocardial infarcts. Hypertension, the patient who has left ventricular hypertrophy. And so it is a really late diastolic sound, so late in diastole that it actually sounds like it comes first. And you'll hear ta-lub-dub, ta-lub-dub, ta-lub-dub. It is late in this diastolic phase, but our ear hears it as though it's the first sound. And there's a couple of rhythms or arrhythmias that don't have atrial contraction. So when you listen to your heart and you hear an extra heart sound, first of all, you need to say, is this an S3 or an S4? Did I hear it early in diastole or late in diastole? Well, that's not always easy to determine. So the next thing you should ask is, does my patient have crackles associated with this? Then it is likely an S3. But also ask yourself, does my patient have atrial contraction? Maybe they're an atrial fib and you can't have an S4 because there's no atrial contraction in atrial fib. So think about what's happening with your patient. I remember saying to a physician one day, oh, I think my patient has an S4. And he kind of looks at me and rolls his eyes. I was a very new nurse. I didn't know enough to shut my mouth. And he says, no, he doesn't. So I should have just walked away. But I said, oh, how do you know? Have you been in to assess him already? He's like, no, Miss Palmer. That was my maiden name. Miss Palmer, what rhythm is that patient in? And I had just finished my rhythm course. So I said, it's atrial fib. And he said, yeah, it is. And then I'm like, oh, yeah, you don't have atrial contraction. So I said to him, it must be an S3. And he turned to the charge nurse and said, who hired the rocket scientist here? And I've never forgotten that. I've never learned to shut my mouth, but I never really forgot how embarrassing that was. So in patients who are really sick, so a fresh MI who maybe is late presentation STEMI, he's come in, he's got a stiff ventricle because he's got a big scar on the front of his heart, his ventricle is overfilled, he might have what's called a summation gallop. And it goes talub-dub-ta, talub-dub-ta, talub-dub-ta. I have never honestly diagnosed a summation gallop. I've assumed they've had one, but most of the patients who have a summation gallop, how would they look clinically? Are we discharging them?
They look sick.
So they
Yeah.
look pretty unstable.
Yep, they're sick. So they've got volume overload related, not caused by the S3, but indicated by the S3. They've got a stiff ventricle. These patients look sick, and so they're usually tachycardic. And so it's hard to tell, talub-dub-ta, talub-dub-ta. I can hear that fine in my heart rate of 50, not when it's 100. But whenever you hear that somebody has a summation gallop, that's indicative of a volume overloaded, clinically unstable patient. They're not the guy who's getting ready to go home. So I always think of murmurs, and murmurs have been hard to, I don't know, murmurs are tough. And so a girlfriend of mine and I came up with Sasmar and Darmus. These are the Murmur sisters. And I always struggle with, oh God, is that a systolic problem? Is that a diastolic problem? So let me introduce you to the Murmur sisters. So I'm really only going to focus on left-sided murmurs. And the reason why is, how come? Why are left-sided murmurs more important than right-sided?
Because those valves do the most work.
Yeah. Our left side of our heart is under higher pressure. Right-sided murmurs, it says they're rare. They're not super rare, but they're usually heard in children or patients who end up with endocarditis related to intravenous drug use. So although IV drug use has become much more prominent in Canada, the murmur related to it is probably the smallest thing that we need to know about IV drug use, to be honest. But the murmur of left-sided valve is important. And so when we think of Sasmar and Darmus, it's a way of discerning which is a systolic murmur and which is a diastolic murmur. So a systolic murmur happens between your lub and your dub. So S stands for systolic. And what does AS stand for? Think about murmurs.
Aortic stenosis.
Aortic stenosis. So one systolic murmur is aortic stenosis. What does MR stand for?
Mitral regurg.
Mitral regurg. So the way to remember SASMR or the systolic murmurs is aortic stenosis and mitral regurg. And then our diastolic murmurs or DARMAs are the ones that occur between a lub-dub. So lub-dub swish, lub-dub swish. And I find diastolic murmurs much more difficult to hear than systolic murmurs. The easiest murmur you're ever going to hear is aortic stenosis. So when somebody comes in for a TAVI, go in and listen to them. The cool thing is to listen to them pre-procedure and post-procedure. That systolic murmur should be much different after the procedure than before. So when I think of DARMAs, what is AR?
Aortic regurg.
Aortic regurg. And the tough thing is aortic regurgitation is also called aortic insufficiency, AI. Many surgeons call it AI. Or aortic incompetency. But the true textbook name for it is aortic regurgitation. And what does MS stand for?
Mitral stenosis.
Yes, so my diastolic murmurs are aortic regurg and mitral stenosis. So now I'm going to tax your brain. These are left-sided. So the aortic and the pulmonic valve function together. The mitral and the tricuspid valve function together. So down at the bottom of your page is a chat box. I would like you to tell me, what are the right-sided systolic murmurs? If aortic stenosis and mitral regurg happen on the left, what are the systolic murmurs that happen on the right? Yay! So in our text box, we have pulmonic stenosis and tricuspid regurg for our systolic. So when you think of what valves function together, your aortic and your pulmonic open and close together. When you think of your mitral, you should think of your mitral and tricuspid open and closing together. Awesome, well done. So when you think about the diastolic murmurs, what would be, oh, sorry, I think I heard a question. No?
Oh no, I hiccuped.
Okay. Because you have good snacks probably, right?
We had chips and guac.
See? I'm jealous. I haven't had time to eat yet today. That's not a bad thing, but. So, anybody want to be brave and type in the diastolic murmurs that might happen on the right side? So aortic and pulmonic, open and close together. Mitral and tricuspid, open and close together. Awesome. So pulmonary regurg and tricuspid stenosis. Yeah. So it's all about thinking what valves open and close together, and where you're listening on the chest. I'm not going to hear aortic stenosis down here in my mitral area. Now, I might if it's super loud and it radiates, but when I listen to my aortic area, I'm going to hear it very loud there. And then as I move away from that aortic area, that sound will diminish. Aortic stenosis often radiates up to the neck. And if you don't listen to heart sounds, you could mistake it for a carotid bruit. So a murmur is a sound heard by turbulent blood flow in the heart. Anytime it's outside the heart, we call it a bruit. But it's the same thing, it's turbulent blood flow. So Sasmar and Darmus are an easy way to remember systolic and diastolic heart sounds. So this just goes over what we just talked about. So somebody gave this page to me probably 25 years ago, and I have not been able to part with it. So I honestly only care about right or left-sided murmurs because I care for adults. I don't look after pediatric patients who are usually the patients who have pulmonic problems. And so I like it because it tells me the problem, aortic stenosis, and then it tells me where do I hear it best, where does it radiate to, what is the intensity like, because sometimes it's very loud, but oftentimes it can be quite soft. The pitch, but I really like the assessment tip. It says systolic murmur best heard if patient is sitting or leaning forward. And some of these murmurs are better heard when you do an isovolumetric exercise. And so we're not going to ask Buddy to do jumping jacks or anything. We're going to ask him to open and close his hands like this. That's an isovolumetric exercise that can change the quality or sound of a murmur. And find your go-to physician and latch on to him or her and follow them around creepily, because they will love to teach if they know you want to hear about heart sounds. There's one little bald guy that I love to attach myself to, and his name is Dr. Robert Teskey, and he is my kind of heart sound guru. So find your go-to girl or guy and hang on to them. And make sure they have your cell phone number, because I periodically get a text from Bob that says, "Hey Sue, really cool heart sound in 5A57. Like, yes. So I go up there. Or, do you have any students with you today? Bring them up to room 60. Really cool sounds. So be a geek. It's okay. Nobody cares. They actually think it's kind of cool. So you might want to explain why you're creepily following them around, but if they know that you want to learn more about heart sounds, then they'll really help you out. Oh, I thought I had one more slide in here, which is, I'm just going to write it here. It's a website that I recommend to everybody, and it's www.easy, Auscultation, AUSCULTATION.com. And I can send that out in an email if you like afterwards. EasyAuscultation.com. It's great. It does heart sounds, but also does lung sounds. I recommend it to all of the new nurses that I educate. And so I will send that out by email. Just writing myself a note. Okay, so that's kind of heart sounds. Does anybody have any questions or comments thus far? Probably a lot of, hopefully most of this is review for you. No, don't be shy, just shout out, throw out any questions. You don't have to wait till the end, just throw them out as you think of them. Everybody hanging in okay?
We have a question. We have two.
Yes.
Our first one was going back to like the actual exam. Is it like NCLEX style where you answer the question and then can't go back? Or are you able to go back and
No,
forth?
you can go back.
Okay. Question number 2.
Do you think they'll ask, is such and such heard best at the mitral area? Or do you think they'll ask, like, is it best heard the 5th intercostal space, left sternal border?
So a knowledge question would say, is it heard best in the mitral area? A hard knowledge question is it heard best in which area? So you would have to describe the area.
Okay.
And then a critical thinking question would be, a patient has an extra heart sound heard in the 5th intercostal space, midclavicular line. Their respiratory rate is 37. They went on with a few physical assessment parameters. What heart sound would describe, what best describes this heart sound? Then they might have S1, S2, S3, S4.
Okay.
Okay.
Yeah, so they can turn any question into a knowledge and application or a critical thinking question just by adding or taking away.
Okay. Thank you.
Good questions. Okay, so the nursing scope of practice, when we think about interpreting a 12-lead ECG, it's really blurred. So what you need to remember is this exam is designed for a nurse who's been practicing for 2 years or more in critical care. So they're never going to say, hey, diagnose this hemi block. Let's see if this is a STEMI or a left bundle branch block using Scarboza criteria. Those are just not things that you need to know. But you do need to know contiguous leads, a little bit about bundle branch block, and a few other things that I'll focus on next. So this is a bad drawing, but you get the message. So when we look at coronary circulation, you have to understand coronary circulation, because then an ECG makes more sense to you. So this is a patient who is right dominant, and about 85% of our population is right dominant. And what does that mean? That means, let me just get a pen here, and let me get a better color. Okay. That means that this part of the right coronary artery supplies the posterior part of our heart, or better defined as the posterior descending artery in a right dominant patient comes off of the right coronary artery. In a patient who is left dominant, which accounts for somewhere between 7 and 15% of the population, that posterior descending artery doesn't come off of the right coronary, it comes off of the circumflex. And then there are a group of patients, probably account for 6 to 8% of the population, where the posterior descending artery actually comes off both the RCA and the circumflex. And they call that codominance. Your questions are going to focus on right dominant because that is the majority of the population. And so when we look at this picture, I think maybe I have drawn the left main coronary artery a little bit long. It's usually not that long. And I think anatomically I kind of have it screwed up a bit, but that's all right. It bifurcates into the LAD and the circumflex. And you can see anything that's dotted here goes around the posterior part of the heart. So we have 3 coronary blood vessels. The PDA comes off of the right coronary. The diagonals come off of the LAD, and the obtuse marginals come off of the circumflex. That's pretty much what you need to know. If you work in cardiac surgery, then you'll be familiar with diagonal branches because we often bypass them. If you work in cardiac surgery, you'll also be familiar with your obtuse marginals because we also bypass them frequently. So they are significant arteries that when they become atherosclerotic can impact the patient's quality of life or can cause a STEMI. So we pay attention to the 3 main coronary blood vessels. Oops. So here is a picture of the right dominant, the codominant. So you can see here that my posterior descending artery traverses down the posterior groove in the back of my heart. This is a patient who has codominance. Both his RCA and his circ are feeding the posterior part of the heart. And then here is a patient whose PDA, posterior descending artery, comes off of the circumflex. Now, I know these are simplified cartoony pictures and they're much more interesting on angiogram, but it gives you an idea. So coronary circulation is unique, it's interesting, and each of our coronary blood vessels kind of traverses or fits into what's called the grooves in the heart, usually the AV groove. So our left main originates in the left coronary sinus, and then it comes down, it bifurcates into our LAD and our circumflex. The LAD traverses or runs down the anterior intraventricular groove. So kind of protects it a little bit. But there are some people who are born not with a bifurcation of their left coronary, but a trifurcation. And we call this third vessel a ramus. And it becomes important when we're doing coronary artery bypass grafting. It's kind of like you can't tell who's born with it. You diagnose it on angiogram, and between 10 to 30% of the population have this trifurcation. It's kind of interesting to see it on angiogram. So this is, and I don't work in a cath lab, but I'm assuming more of a caudal view looking down. And you can see your left main here, your LAD, your ramus, and your circ coming around. So I like to look at my cup as half full. I have an extra blood vessel to feed my heart. But then there's the pessimistic view. Oh God, I have another one to get atherosclerotic. No, the more feed, the better, I think. But again, This may be an important blood vessel, or it may be unimportant. It depends on how much myocardium it feeds. So it can either behave like a large obtuse marginal, which comes off of the circumflex, or a diagonal branch that comes off of the LAD. And it usually supplies the lateral free wall of the left ventricle most of the time. Sometimes, or most of the time, it doesn't fit into a groove like the other coronary blood vessels. It simply kind of sits on the free surface of the left ventricle. And sometimes, in rare cases, it can cross over the aorta and the pulmonic artery. Actually have a picture of a cardiac cath done a couple of years ago that shows that. And it really, when the girls came in and showed me this picture, like, oh, that's totally cool. Let me get a photocopy of that. I can use it in a presentation. But it was actually quite cool because it was laying over the aorta. Not great if you're in a motor vehicle accident and it compresses. All kinds of funky things can happen to you in that manner. So what do we have to remember for 12 lead? This is a right dominant patient. And so my ECG that's done in North America is always going to be laid out in this manner. Lead 1, 2, and 3 in the first column, augmented voltage right, left, and foot in the next column, V1, 2, and 3 in the third column, 4, 5, and 6 in the fourth column. So we divide these things up as contiguous leads, meaning leads that look at the same part of the heart. So tell me 2, 3, and AVF are your inferior leads. Who is the boy or the blood vessel that feeds him? You have a 33% chance of getting it right. So type them in the chat box.
Yay.
Perfect. RCA. So if I come in and I have inferior elevation in 2 or more contiguous leads, that tells me I'm having a STEMI. It's in my inferior leads. So 85% of the time, it's going to be my RCA that is a culprit. Next leads I look at, some people look at V1, V2, V3, and V4 all together. But the majority of people will divide them. V1 and V2 look at the intraventricular septum. And I'm just going to go back here to a picture for a minute. And here is my LAD. One of the first branches off of my LAD is my septum. And so when we say proximal LAD, we say proximal means closer to the origin or opening. So V1 and V2 look at proximal LAD blood flow. And V3 and V4, we call these the anterior leads, and they look at mid or distal LAD circulation. Then we have 4 cameras, and I call them cameras because this is where they stand and take a picture. So they're a camera. V5, V6, lead 1, and AVL all look at the lateral part of my heart. So when I think about which coronary blood vessel, just type into the chat box, which cameras, these V5, 6, lead 1, AVL, what blood vessel are they looking at? Yes, so my circumflex. And oftentimes you will hear Lead 1 in AVL referred to as high lateral or proximal. V5 and V6 look more mid or distal circumflex. So you have to know that. You have to know your contiguous leads and the blood flow related to each. There's a whole lot more complexity to hypertrophy and enlargement, but I tried to summarize it in one slide. So we have 4 chambers, and you can have enlargement of each of them. When I look at my right atrium, I'm looking for what's called a peaked prominent P. I call it PPP, a peaked prominent P. Your P wave will be greater than 2.5 millimeters in height, and that will indicate right atrial, and we call it enlargement. We don't usually call atrial hypertrophy. And the reason why we don't is because there's not much muscle mass in the left and right atriums. So they often just enlarge and not hypertrophy because there isn't a lot of muscle mass there. So peaked prominent Ps indicate right atrial enlargement. Sorry, just have to answer a text from work. You gotta love the days when they tell you, oh yeah, we have a new balloon pump, but because of COVID, we haven't been in service yet, so we won't use it until they use it, and nobody knows how to use it. So frustrating. Thank goodness it's similar.
I walked into that this morning.
I got like 5 texts. So when I text a perfusionist, he types back, we haven't got the in-service yet either, so I'll read the manual and go up and deal with it. It's really not a big deal because it's quite a nice device and not that much different. But so when I look at peak prominent Ps, I say, oh, I have right atrial enlargement. When I have P mitral, I say, oh, it's an M shape to my P. That tells me I'm looking at left atrial enlargement. When we talk, when we talk about hypertrophy of the left ventricle, it's all about voltage. And whenever you hear or see someone say, yes, he meets voltage criteria for left ventricular hypertrophy, what they have done is they have looked at V1 or V2, and they have said, who has the deepest S wave? And when you look here, this is your S wave, and when I count it, it's about 5, 10, 15, 20, I'm going to say 25 millimeters deep. And then I'm going to go to V5 or V6, and I'm going to see who is taller. And so obviously in this example, V5 was taller. So I count how tall he is. 3, 8, 13, 18, 19, 20. In a patient who is 35 years of age and older, which this is an adult exam. So in a patient who's 35 years of age and older, if the voltage, when you add the 2 of these up, and so in this guy, I get 45, if it's greater than 35 millimeters, then he meets voltage criteria for left ventricular hypertrophy. So there's over 100 different criteria for assessing left ventricular hypertrophy. Voltage criteria is the most common. And so when you look at an ECG and you have super, super tall QRSs, in V4, V5, and V6, you should always question, hey, does this guy have left ventricular hypertrophy? Most common reason for LVH is hypertension. And then right ventricular hypertrophy, what you really need to understand is chamber enlargement and hypertrophy only shows up on an ECG about 40% of the time. That doesn't mean your patient doesn't have it. It just means it doesn't show up on ECG. Clinically and on echo, they will have it, but it might not show up on ECG. Finding right ventricular hypertrophy, yeah.
Sorry, does it just not show up because it's not severe enough, or some people?
So
It
it
doesn't
depends on electrode placement. It depends on obesity and how much tissue there is between where the electrode is placed and where the heart is. And yes, and it could indicate severity. So in early stages, will be less likely to show up than in later stages.
Okay,
Yeah,
thank
good
you.
question. Right ventricular hypertrophy is hard to find on an ECG. My dad had right ventricular hypertrophy. The reason why he had right ventricular hypertrophy is he was a truck driver and he smoked unfiltered cigarettes, a pack a day for probably 50 some years. And so he had pulmonary fibrosis and what's called cor pulmonale. And so when his right ventricle ejected into its pulmonary system, he had really high afterload or high blood pressure in his pulmonary system. And so his right ventricle had to work hard. And so when you work hard, you build muscle. Well, that's great on your biceps and triceps. It's not great when it's in your heart, because now you have more muscle to feed. And depending on how it grows, you may decrease the size of the chamber. But the cool thing about right ventricular hypertrophy is you have a totally opposite look to your precordial leads or your chest leads. You have an abnormal R wave progression. So in a normal ECG, V1 should be negative. So this is what V1, whoops, that's a bad drawing, but V1 should look like this. V2, predominantly negative. V3 is what we call the zone of transition, where you get an equally positive and an equally negative. Then your V4 should be tall. Oops, not that wide. V5 will be your tallest QRS because electricity in a normal heart will come directly at it. And then V6 will be just a little bit shorter than V5. When you look at this example, you have a positive QRS in V1. There's only 5 reasons for a positive QRS in V1. And one of those is right ventricular hypertrophy. And that's because the electricity is not traveling down this way like it normally does. All of the muscle mass is over on the right now, or the biggest amount of muscle mass. And so when you think about it, if you can look in the video and look at me, my fist is V1. Normally, the electricity goes down and away from it. But when I grow a big right heart, the electricity is coming towards V1. And whenever electricity comes towards a camera or a positive pole, you get a tall QRS. So right ventricular hypertrophy is rather unique. whenever you look at an ECG, you will have an abnormal axis. And the axis, all that is kind of a hexaxial reference system. It's a round circle where the main wave of electricity goes down and to the left. But now there is more muscle over here in the right. So you actually get a right axis deviation in right ventricular hypertrophy. And you can tell that by having a positive QRS in V1. The electricity is coming towards it, so you get a positive electrode. And so right ventricular hypertrophy, you have to have a right axis deviation. You have to have this abnormal R wave progression. So I wouldn't spend too much time on thinking and learning about that. Just know that it's all about voltage when you talk about left ventricular hypertrophy, and it's all about abnormal R wave progression when you talk about right ventricular hypertrophy. And then bundle branch blocks. People get really stressed out about bundle branch blocks, and they're really quite simple. First of all, your step one is you look at all 12 of your leads. Because if I was just looking at lead 2 in this example, my QRS is not fat in this example. But when I do a 12 lead, I look at all 12 leads and I say, hey, I have a wide QRS in V1, V2, V3, over here in lead 3. So as long as I can confirm that there is a QRS that is at least 0.10 seconds in duration, then I have a bundle branch block. So then I proceed to step number 2. If I don't find a wide QRS, I don't have a bundle branch block. Then I go to step 2 and I look at V1. V1 should be negative. If my QRS is positive in V1, I have a right bundle branch block. If my QRS is negative in V1, then I have a left bundle branch block. It's as simple as that. Gets much more complex when we talk about hemi blocks. But this exam is not going to ask you about a hemi block. It's going to ask you about a right bundle or a left bundle. And so you diagnose it by finding a wide QRS. Then when you find that wide QRS, you go to V1. If the QRS is positive, it's right bundle, like in this example. The QRS in left bundle branch block will always be wide and ugly looking. It's wider in left bundle than it is in right bundle. And there's always some kind of underlying pathology related to a left bundle branch block. I went to get a pedicure a couple of weeks ago, and the esthetician says to me, well, I don't think much of your heart center. I said, oh, okay, how come? Well, I went into the emergency department and I was having chest pain, and they did an ECG and they told me I had a left bundle branch block and not to worry about it, I should go see my family doctor. So I'm talking to her, I said, so are you sure they said left bundle branch block? And well, I mean, whatever, left or right, what's the difference? And thought, actually, there's quite a big difference. So you can have a right bundle branch block for a number of reasons. It can even be a normal variant. But a left bundle branch block in the presence of chest pain always needs to have an experienced physician look at it to determine, is this a new left bundle branch block, a STEMI equivalent, or is this patient presenting with atypical chest pain and they already had a pre-existing left bundle branch block. So important to try and rule that out. I said to her, I don't think so. We have some pretty great emergency room physicians. And so I don't think if they thought that you had a new left bundle branch block. So she said to me, well, I went on to WebMD and it said that I was having a heart attack if I had a left bundle branch block. And so I said to her, my husband uses WebMD too. And you know what I do to him when I catch him? I slap him upside the head. Listen to your healthcare provider. But just know that a new left bundle branch block is a STEMI equivalent and is an indication for thrombolytics. So I sent you a Word document that gives you the 6 steps of how to interpret a 12-lead ECG. And so I don't think they'll ask you questions about axes because nobody really cares about axes. They might ask you about peaked T waves. So can anybody type into the text box why you might have a peaked T wave? Excellent. Hyperkalemia. And so it's the most common reason for a peaked T wave. Arrhythmias. Like I said, that is the first step in interpreting a 12-lead ECG, but it might also, because there's not very many graphics on here, they're more inclined to describe things as opposed to actually putting a rhythm on there, which frustrates me. I would much rather you have the rhythm and then there's no misinterpretation of the data. So let me just check my, okay. It's 1:30. Let's take a 10-minute break. Go refresh your caffeine. Take a little nature break and we'll come back at 1:46 and we'll start with heart failure. Okay.
I'm really worried Karen's dog is stressed.
Karen's dog looks like he's got the life of Riley.
They have a personal life.
Karen's dog looks like he takes way too much of the bed for my liking. Yeah, I think that's why I don't have a dog. Because when we used to, he took over the bed. And you know what? I ain't leaving, so Pat had to.
There's another pup.
Oh, he's so cute.
Oh.
Yeah,
mine
are
definitely
you at
do.
your house or Jesse's? Oh, sorry. I'm going to unmute you.
We're at Jesse's. I don't get any puppy snuggles.
Well, because I was going to say, I bet you your people that live downstairs be having a fit about that dog.
Well, you know how I feel about them.
Hilarious. Okay, take a break. I'll see you in 10. Okay, guys, just give me a sign that you're back among the living. Virtual classrooms are great, except when you're not sure if anybody's dead or alive.
I'm here.
Cushy, I see you're wide awake and like engaged, impressed. Wow, this is kind of boring stuff. Anyway, we'll plug through. This video that I'm going to show you is only 3 minutes long. When I bring it up, I can't see your faces anymore, so I will need somebody to just come on to the mic and tell me if you can hear the sound or not. So bear with me. You may get a advertisement for God only knows what, because it's a YouTube, but I do use YouTube quite a bit. Well. Oh, for God's sake, I just had it playing 5 minutes before we started. Now it will probably tell me that I have to sign in because I'm not the right age or something. No.
Despite ongoing advances in the management of chronic heart
Can you hear
failure,
this?
patient outcomes for acutely decompensated disease have not improved. Across Canada, patients hospitalized for heart failure continue to suffer frequent complications, and 16.5% die during their initial hospitalization. An examination of the pathophysiology of acute decompensated heart failure identifies promising new avenues for treatment. During heart failure, the heart cannot circulate enough blood at normal cardiac filling pressures to meet the metabolic needs of the brain, kidneys, heart, and other vital organs. The body responds by releasing neurohormones. Certain neurohormones help maintain blood pressure, but over time, they cause heart failure to worsen. One of these neurohormones is renin, released by the kidneys in response to decreased perfusion and increased sympathetic activity. Renin activates the renin-angiotensin-aldosterone system, or RAAS, by cleaving angiotensin contractility, in addition to causing arterial and venous constriction. Over time, chronic volume overload and the activity of angiotensin II, aldosterone, and endothelin stimulate pathologic cardiac remodeling. The interstitial fibrosis and myocyte apoptosis associated with cardiac remodeling decrease heart wall elasticity, further inhibiting the heart's ability to relax and pump effectively. In summary, the neurohormonal response to heart failure causes vasoconstriction, fluid retention, and increased heart rate and contractility. In turn, these processes initiate a vicious cycle of further myocardial injury and escalating heart failure. Fortunately, additional neurohormonal responses modulate the activity of the RAAS, endothelin, epinephrine, and norepinephrine.
So that is probably one of the best videos that I have watched to understand the pathophysiology of heart failure. And so where are we at? Let me find my presentation here. The pathophysiology of heart failure is super complex. So if you want to go back and watch that video again a couple of times, you can just click on it. Hopefully it'll work in your browser. But what we try to do to help heart failure patients is to overcome all the compensatory mechanisms within our body. So beta blockers, diuretics, and the super important ACE inhibitors really are targeted at decreasing all of that compensatory mechanisms that actually cause things to be worse than they are better. Now, I just want to backtrack for a minute before we go on. And I think I phrased it incorrectly. When we were talking about chamber enlargement, I don't know if I made this clear. I don't think I did. I said 40% of the time, it doesn't show up on ECG. I think I worded it differently earlier and said that it only shows up 40% of the time. No, it doesn't show up 40% of the time. That doesn't mean it's not there. So 60% of the time it'll be on ECG, 40% of the time it won't be there, but that doesn't mean that clinically the patient doesn't have left or right ventricular hypertrophy. So sorry about that. I think I need to rephrase that. So when we think about heart failure, we in Canada use the New York Heart Association classification. There's also the Killip classification. Karen, that dog's just killing me. He's a riot. So New York Heart Association is the classification that we use in Canada. And class 1 and class 2 patients are not going to be who you're going to see. They are patients who are going to their family doctor with a little bit of peripheral edema, maybe shortness of breath when they do a few flights of stairs, and they're being managed with diuretics. The class 3 and class 4 are the population that you will see in acute care facilities. And so class 3 is barely able to do their activities of daily living, and class 4 is the patient who is symptomatic at rest. So you will not see on your exam anything about HFrEF and HFpEF. What you will see on your exam is systolic heart failure and diastolic heart failure. So systolic heart failure, now called HFrEF. I don't even know where they get these names, but HF-REF stands for heart failure, reduced ejection fraction. And so this is the patient who has an EF of less than 40%, also known as the old systolic heart failure. And then the HFpEF, or heart failure preserved ejection fraction, is the old diastolic heart failure. And that is the patient who has a preserved ejection fraction greater than 40%, but oftentimes it's in the mid-50s. And basically their problem is not got to do with strength of contractility, but more the inability to relax and let the ventricle fill. And so they have all the clinical symptoms of heart failure, but when they do an echo, their ejection fraction is greater than 40. Now, I read an article the other day that they're thinking of adding a third parameter to this called HFmEF. Like, oh my God, who gets paid for this stuff? So HFmEF is that group of patients that fall in the middle. The M stands for mid ejection fraction, and that's the group that are in the 50s. So the EF is in the 50% range. just know that your exam was written before HFrEF, HFpEF, and HFmEF were ever thought about. And so you're going to hear terms like systolic heart failure and diastolic heart failure. Systolic heart failure has an ejection fraction of less than 40%. Diastolic heart failure has an ejection fraction closer to 50, but definitely greater than 40%. So they both have the same clinical symptoms, but the reasons for it are different. So this is a very busy looking slide, but this comes right out of the heart failure guidelines as to what are the risk factors for developing heart failure, what are the symptoms, the signs, key ECG findings, key X-ray findings, and then just a little bit about BNP. And so Emily has informed me that they now do BNP testing in Manitoba. They were one of the last provinces to adopt it. BNP testing is expensive. And so what they're suggesting is that we use BNP as an initial guiding exam. But once we've diagnosed heart failure, don't keep measuring it to see how they're responding to treatment. Look at and use your assessment parameters. Hey, patient says he feels better. Patient's now 3 liters negative. Patient's blood pressure is stable. His heart rate is reduced. Use all of those clinical indicators of patient improvement as opposed to measuring a BNP and saying, hey, my BNP was 3,000 and now it's down to 900. He's better. No, it's far better to look at symptoms and determine that. So BNP is definitely something that we use. BNP is called brain natriuretic peptide. We also have atrial natriuretic peptide. These peptides are released from our heart and our brain whenever there is stretch. They're basically hormones that are in our body that can cause a diuresis. So our body says, hey, my heart's being all stretched out because it's volume overloaded. We release BNP into the plasma, and it's supposed to act as a natural diuretic. We haven't been hugely successful in synthesizing this and making artificial BNP. There was probably 20 years ago now, a medication called nestriatide that was kind of synthetic BNP, and we had really high hopes for it, but it's kind of fizzled out. So I don't expect you to know what drugs and what doses because they're not going to ask specifics like that. They're also going to be aware that different labs measure different blood work. And so they're not going to give you a hemoglobin of 130. They're going to say an elevated hemoglobin, a decreased hemoglobin. They might give you a serum potassium because that is a standard measurement across Canada. But all of the other blood work will probably just tell you an elevated, a normal, or a decreased. And that's because sometimes we measure it in millimoles per liter, or other people measure it in deciliters. So it will be different, and that's why they've chosen not to pick any particular parameter, except for, and I think it's all of our electrolytes are measured universally. So when somebody says they have heart failure and they're receiving triple therapy, what that means is that they are receiving a beta blocker, an ACE inhibitor, and what's called an MRA, and I never can pronounce this name properly. It's a mineral corticoid, an MRA receptor antagonist. And those two drugs that we have are spironolactone or eplerenone. Does anybody know which of those drugs give you man boobs or gynecomastia?
Spyro.
Yes. And I can't speak from experience, but patients tell us man boobs are really painful. Gynecomastia is very painful. And so for that reason, you will see eplerenone ordered more often than spironolactone, although it is more expensive.
Is there another name for eplerenone?
Yep. Yep. Nope.
Not coming to
even
you right
in my
away?
brain. Nope.
Okay.
Not even
I'll-
coming to my brain.
I'll look it up here really quickly.
Okay. And then tell us.
Yeah, I'll put it in the chat.
Perfect. Thank you. So your exam is not going to be asking questions about ARNIs, the angiotensin receptor nephrolyzing inhibitor. They're not going to be talking about the IF inhibitors or the SGLT2s, because all of these are recommendations after your exam was developed. So they will be focusing on everybody gets diuretic therapy. The sicker patients, once we get them out of intensive care and into a step-down unit, will be managed with definitely ACE inhibitors. And I would anticipate a question like maybe the man boob question, or they wouldn't state it as man boobs, they'll call it gynecomastia. But they might also ask about, what if your patient developed a dry hacking cough while on an ACE inhibitor? What would be a suitable alternative?
Would you use like an ARB?
Yep. So patient has this dry hacking cough, new since the start of ACE inhibitors. Then they will DC the ACE inhibitors and they will add ARBs. Frustrating thing about this exam is it's not as current as we at CCCN want it to be. I would love to see some new questions about these medications because they are really becoming huge treatment factors in heart failure. Stay tuned in November because the Canadian Council of Cardiovascular Nurses is partnering with the Canadian Heart Failure Society, and we're doing an evening presentation on SGLT2 inhibitors and their sort of off-label use in non-diabetic patients, but there's strong evidence for their use in heart failure and even in non-diabetic patients. So stay tuned for that in November. I think it's the 16th or the 17th. And Emily and Sheila, they're one of the people who is speaking is a nurse practitioner from Winnipeg. Estrelita has given us a recommendation for the person to speak. I think her name is Lori. Oh, I can't think of her last name now, but she's a nurse practitioner in a heart function clinic. So stay tuned for that. So I in no way am calling our patients donkeys. So, but there is this donkey analogy about heart failure. So here is what typically looks like a decompensating heart failure patient. They come in and they're unable to carry out the activities of daily living. They're diaphoretic, they look exhausted, they're sitting bolt upright in the bed, their respiratory rate is up, their weight is up, and they are miserable. And so it feels like the weight of the world is on their shoulders. And so what do we do? Once we get them dried out, and this is important, we do not give beta blockers to patients who are in gross heart failure or acute heart failure. If they were on them at home, we may even stop them, or likely will stop the beta blockers until we get them dried out. And the reason why we then return to beta blockers is basically it's an energy saving mechanism. It takes away some of the compensatory mechanisms within our body, and it conserves energy. So patient starts to feel a little better. So dry them out, add beta blockers. That's one of the first drugs that we will use in heart failure patients besides diuretics. So diuretics are just a given. Then we say, okay, how do we reduce the workload? So we've reduced it with diuretics already, but also by adding ACE inhibitors, we also take away some of the negative effects of our compensatory mechanisms in our body, and it actually makes us more able to carry out activities of daily living. Then there are some patients who may benefit from cardiac resynchronization therapy, and I'll talk about this in a few minutes. But CRT is also the same thing as a biventricular pacemaker. When somebody has a wide QRS, for example, a right bundle or a left bundle branch block, if you look in my video, so see me, here is a normal ventricular contraction. My right and my left are contracting simultaneously. In the middle is an intraventricular sip. Sorry, Shayna, he loves you. He's quite cute. So in the middle is this intraventricular septum that should stay in the middle when you get equal contraction. But when you have a bundle branch block, this is what's happening. Is one ventricle is contracting before another. And so your intraventricular septum swings back and forth. And what that does, it impinges upon your outflow tracts and decreases your cardiac output. So in typical or normal pacing, we stimulate the right ventricle first. And so using RV pacing would not help these patients. It would probably make them worse. So what they do, and I think I have a picture of it later, is they put a lead in the right ventricle. They can't put a lead in the left ventricle because it's going to clot and then cause some serious problems. So in order to pace the left ventricle simultaneously with the right, we thread a pacing wire down into the right atrium and into a little venous area called the coronary sinus. And we feed that wire down so that it sits in behind the left ventricle. And then we can simultaneously stimulate both the left and the right heart ventricle together and cause synchrony. And it actually improves our patient's cardiac output and their ability to do their activities of daily living. So sometimes when our patients are not able to take these pharma recommendations, we have to admit them to intensive care units and give them incentives. We call those positive, and pardon my spelling mistake there, positive inotropes. And the two true inotropes that we use in Canada are dobutamine and milrinone. And they are recommended for enhancing contractility. So there are patients that you may be caring for in Western Canada that actually come into a day hospital and get infusions of milrinone or get infusions of dobutamine. And they might get that a couple of times a week to improve their functionality. And so we use these types of medications in our intensive care units, but they can also be used in a well-monitored heart function clinic. So we use those when we cannot use our regular pharma regime. So this is kind of the donkey analogy of, you see him, he looks bad. You slow him down with beta blockers. You add and make him more efficient with ACE inhibitors. It's a mainstay that you give diuretics. And then if your patient is not doing well and contractility is an issue, then you're going to add a positive inotrope, dobutamine or milrinone. So here's a picture of cardiac resynchronization therapy. So the device actually has 3 leads, one that sits in the right atrium to cause atrial pacing, one that sits in the right ventricle, so down here at the apex. And then you can see this 3rd lead here is threaded in through the coronary sinus, and it goes down in behind the heart and stimulates the left ventricle in that fashion. So cardiac resynchronization therapy, also known as BiV pacing, is to improve ventricular dysynchrony. And it's actually a very good thing.
So do you see the need for CRT in a HFpEF or HFrEF patients more?
So a
often?
HFrEF.
Okay.
Yeah, yeah. So the PEF guy is much more difficult. Actually, it's usually a woman. Much more difficult to manage because there's not that many meds that actually help our ventricle relax.
Okay.
Yeah, it is. It's a more difficult disease to manage.
Okay.
Figures women would be more prone to it than men. So then there's a group of patients who have heart failure and a low ejection fraction. And so right now it's a class 1A recommendation, meaning the highest level of evidence for patients who have an EF of below 35% to have an implantable cardioverter defibrillator. That's because they are at huge risk for sudden cardiac death. And so Holly's budget may be impacted. In a patient who has a bundle branch block, significant heart failure, and a low ejection fraction can get the Cadillac of devices. CRT with a defibrillator built into it. It's kind of the Cadillac of devices. It's expensive, but it definitely improves quality of life with the CRT component, but also gives you some longevity because it prevents sudden cardiac death. So people always say, well, how do they decide who gets what? There's very clear Canadian Cardiovascular Society guidelines on how do we manage patients who have heart failure. And oftentimes one of the first questions they ask is there an ischemic cause for this heart failure? And if there is, then you ask a surgeon, is there any way that revascularizing this patient surgically, or even with PCI, would improve his heart failure? If there is not, then obviously he's not a surgical candidate, but then they decide, okay, do I put in an ICD or do I put in an ICD with a biventricular pacemaker in it? And so what they do is they wait at least 3 months from the insult, if you've had a myocardial infarction or you've got admitted with your first diagnosis of heart failure. They kind of give your heart a little bit of time to recover on its own, and then they bring you back, do an echo, and determine, hey, this guy has a wide QRS and he has a low EF. Then he's going to get the Cadillac of devices, CRT and ICD. But maybe he doesn't have a wide QRS. Maybe he doesn't have any of that dysynchrony, and he'll only get an ICD. So I just wanted to show you that there is evidence. It's not Mr. Dr. So-and-so puts in more because he gets more money. That's often what I hear. No, there is evidence behind what we do. So how does an ICD work? So an ICD recognizes a wide, rapid rhythm. If it sees VFib, it just shocks. But if it sees ventricular tachycardia, it will look and say, hey, how fast is this guy's heart going? A traditional or typical VTAC will be at a rate of around 188. The pacemaker part of the ICD will say, hey, I'm going to pace this guy at a rate faster than his VTAC. And then I'm going to abruptly stop. And so you can see that anti-tachycardia pacing happened right here. They stopped the pacing and the patient's own intrinsic beat took over. So they will try anti-tachycardia pacing initially. If that doesn't work, then they will shock the patient. Has anybody ever heard a patient say what they felt like?
Yeah, it's like getting kicked in the chest by a horse.
Yeah. So even people that live in the city will describe getting kicked in the chest by a horse. It's very painful. It's very alarming. And I would expect that you would have a psychosocial question related to devices. So allowing the patient to verbalize his fears and validating those fears are important. So you don't have to give your opinion. We actually don't want you to give your opinion. We want you to listen to the patient to validate that, yes, I understand that you are fearful, that you're scared, that you're terrified. What can I as a nurse do to help alleviate some of those? Well, for most patients, that's education. And so I would suspect that that would be a very good question. If your patient is in acute decompensated heart failure, we can also use some temporary devices. And so a balloon pump, something called an impella. There's also something called the tandem heart. And then probably the highest level of support is ECMO. I really like this next picture because it kind of looks at all of the types of ventricular assist devices and how they work. So is it centrifugal flow? Is it axial flow? So a balloon pump will still give a patient blood pressure and pulse. But once you go to continuous flow, it takes away that pulse and blood pressure in the traditional measurement. And so it kind of freaks people out when they don't see an art line blood pressure. How do I know my guy's alive? Well, you have great assessment skills. You have to use them. So I would not expect any questions about any of these because they are unique to centers that do cardiac surgery. And a nurse of 2 years graduating probably isn't looking after the sickest ECMO patient. It's kind of a staggered, get you comfortable. So I might expect maybe a teaching question, like something called destination therapy. So there are patients who are not candidates for heart transplants for whatever reason. Maybe it's their choice, or maybe there are other comorbidities that prohibit them. And so there are patients who live with VADs, ventricular assist devices, whether it be a left ventricular assist device, a right ventricular assist device, or in this picture, a biventricular assist device. You'll often hear this referred to as destination therapy, and it's basically the patient has this inserted in Atlantic Canada. It's only done in one spot. That would be, we have to send our patients to a neighboring province. But if you work in Ontario or bigger centers in Alberta and BC, then they will do the VAD insertion right at your facility. The important thing is these patients often know more about the device than the nurse looking after them. And so listen to your patient. I can see this being a great psychosocial question. And you know what? If you break sterile technique, that patient's going to call you on it, and they should. The patient is a sitting duck for infection. He's got 2 large, for lack of a better word, hoses coming out of his heart connected to a centrifugal pump and a battery pack. And so if you go in there, you haven't washed your hands, you haven't properly gown gloved and masked, and you're starting to dig into this man's dressing, he's going to tell you pretty quick, no, you didn't wash your hands. Nope, you didn't gown up properly. And I really admire those patients. So kudos to them for being their own advocate. Just remember that this patient's probably biggest fear is that he doesn't have a generator in his home, and we live in Canada and we have crazy weather. And oh my God, when I go to bed, I plug this sucker in. What if the electricity goes out? It's an absolute valid concern. So a lot of these patients will ask, how do I go about achieving funding? I need a generator in my house, or at least I need an adequate battery pack to keep my VAD going. NB Power, New Brunswick Power, and I'm sure every other hydro company across Canada has a priority list. And those are the patients who are on supplemental O2 or patients who have devices that are life-sustaining. And so those are supposed to be the people who get their hydroelectric power reinstated the quickest. I don't know if that works or not, but just kind of interesting. So there's lots of psychosocial things that happen with these devices. And so instead of understanding how all the technology works, I would expect that there would be an ethical question. So they might give you a patient who really is not a candidate for a VAD and you know, ask you to decide how would you respond when the patient says, how come I'm not a candidate? Something like that. So just remember that VADs are an ethical dilemma for many patients, especially when we use it as destination therapy. When we bridge to transplant, not so much ethical, but definitely lots of discussion about when to turn patients' VADs off at end of life and when to turn patients' ICDs off at end of life, and yeah, lots of interesting stuff. All right, so that is heart failure. Quite a lot of information here, aren't we? Okay, we're 2:30. We're doing pretty good, actually. But I am going to stop. And I'm going to ask people how their brains are. My dynamic duo in the middle. How are your brains?
Good.
Good. We have caffeine.
It's nice to review everything that we've been reading. It makes
Excellent.
more sense when you explain it.
Yeah.
We wish you could do a review to us all the time.
Can I just put you in my pocket?
Sure, if I lose a little more weight first, though.
I have big pockets. I have a big butt, so.
Yeah,
Remember
no, I
my
still
mom
need to
said?
lose weight. Is there anything that you're concerned about that you're like, oh God, I wish you'd have talked about that when we did 12 lead, when we did heart failure?
Well, I'm concerned about the whole thing, but specifically, I don't know. I feel good after this, after going over things with you.
Okay, good.
I guess I have a question. So the ethical dilemma question for it's like, what would be the answer, or what would be the, what would you tell people?
Like if they're not a candidate, what,
So,
like how do you tell? Yeah.
so there really isn't a right answer. So what you do is A, you explore the patient's fears and feelings. Always validate how they feel. Like, I understand that you're scared. I understand that you're concerned. And deferring to the doctor is never an appropriate answer on a nursing exam. So it might be in real life, but this is a nursing exam, nursing knowledge, nursing actions. So if they throw in consult the physician, you might do that in real life. You might even consult an ethicist if you work in a bigger center, because the patient needs to understand what the evidence tells us about putting in devices. And so if this man is 86 years old, have you ever heard the term, the self does not age? Never really knew what that meant, but one of the professors in my graduate studies said to us, okay, I want everyone to tell me what this statement means. And she said, the self does not age. And I'm like, oh God, I'm in one of these courses that's painful. But we had the greatest discussion, because at age 56, I don't feel 56. My body feels 56, but my mind does not feel 56. I still say inappropriate, creepy things. You guys who work in the heart center know that all the time. That's because I still think I'm 30 years old. In my mind, I haven't aged. So you have to also think about that in the patient who's 86. Yeah, well, I mean, I know that I can't climb Mount Everest anymore, but in my mind I can. So how come you can't let me live forever? And so a lot of this stuff, you just have to talk to the patient and say, because your ejection fraction is so low, your chances of survival in the next 3 to 5 years are single digit. And so do you want to be continuously shocked? Because after somebody has been shocked, one of the first things they'll say to you, oh my God, I didn't sign up for this. I didn't want this. And they're terrified. And so they're not going to ask you a question that doesn't really have an answer to it.
Okay.
But what's wrong with consulting an ethicist, or bringing in his family to have a discussion? Physicians always talk about this boundary. Know your boundaries. And I'm not sure that I know my boundaries all the time. Because who says that a nurse can't initiate a code blue discussion or a resuscitation discussion? Or do you want a device? I think nurses are in a pivotal position to start that conversation. Because I spend, oh my God, he's hilarious, Shayna.
I got my children childcare. I think I should have got the dog childcare.
Well, he's bored. He wants to
I
play.
was supposed to be at work, and then last minute I got it off to come home to do this, and so he's like, "Oh my God, she's home."
Oh, now she needs to play with me. Hilarious. So I guess what we would do in real life is initiate the conversation. And CNA, who develops this exam, is very on board with this is a nursing scope of practice. Having discussion about end of life is a nursing scope of practice. Just maybe where you work, there might be some boundaries that blur your worldview.
I think though, when they throw that boundary comment at you, it's because you've put them in an uncomfortable position. So they're just like, did you just call me out on my crap? And we're like, yeah, you actually, kind of have to have this conversation. So I started it for you, I've paved the road for you.
You're
Carry
welcome.
on. Yeah.
They don't want to do the work.
Yeah, they're uncomfortable with it. And so their immediate emotional reaction is, I'm going to get mad about this. And I'm going to get mad at you for making me do this. So, but it's really what's in the best interest of the patient. And I think that's, you're doing the right thing because you're doing the right thing for the patient.
Yeah. And there's nothing wrong with saying to the physician, I actually had a conversation with him and his family. When are you available to come and help us complete this discussion? So whenever you're looking at it, CNA is very forward thinking in that fashion, that this is a very acceptable conversation for nurses to have. Yeah. All right. Okay, back to okay, so heart failure is done. Somebody said they wanted to hear about pacemakers. Be careful what you ask for. Pacemakers are painful. So there is an ASBE. It's the national blah, 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 that make decisions about pacemakers. And so there are international codes. And so if you are caring for a patient with a temporary pacemaker, you will always have a 3-letter device or a 3-letter method of pacing. If you're getting a permanent pacemaker, you will definitely have 3 letters. You could have 4 letters, or you could have a 5-letter device. So the very first letter in this sequence is what chamber is paced. And so A, obviously atrium, V, ventricle, D means dual. You're never going to have an O in the first place because that's what a pacemaker does. It paces. So it's going to do something in a chamber. So most commonly, temporary pacemakers will have a V in front of the first letter, in the first position. Then letter 2 and letter 3 kind of go together. So if I turn a pacemaker on in a non-demand mode, what I have said is, hey, you, Mr. Pacemaker, close your eyes, do not look for intrinsic activity, and basically, for lack of a better way to explain it, just shut up and pace. And so that would be the O letter in the second position. And then if a device does not see, it cannot inhibit. So in the third position, you will either have an I for inhibit, a D, which means it inhibits in both the atrium and the ventricle, or an O means it doesn't inhibit. And so what the word inhibit means is to lay back and do nothing if you are not needed. So I think of a pacemaker, and sorry, I don't mean this in a derogatory way, but it's kind of a dumb way to remember it. Inhibition is like a man. He'll work when you need him to, but he doesn't always want to. So let's say you set the pacemaker at a rate of 60. If your own heart rate is above 60, the pacemaker inhibits. It lays back and it has a nap. However, it's always watching when it has an A, a V, or a D in the second position. So what I mean by watching is it is sensing. And so the first letter is the chamber paced. The second letter is the chamber that it is sensing. And so if you have a lead in your atrium, it's looking for P waves because that's what happens in an atrium. If you have a lead in your ventricle and we told it to sense in the ventricle, it's looking for QRSs. And then if you have a dual chamber pacemaker, so a DDD device, that means it paces in both the atrium and the ventricle. It senses P waves in the atrium and QRSs in the ventricle. And if either one of those rates, the atrial rate or the ventricular rate, is faster than the pacemaker, then the device lays back and does nothing and lets the heart's own intrinsic activity happen. We like a demand pacemaker. A demand pacemaker is also known as a synchronous pacemaker. And so it has the ability to see. But whenever you have an O in the second and third position, so maybe you have a V pacemaker, then that means, it's not seeing what it's doing. It just is firing at a rate that you told it to. And so what could be the fear related to an asynchronous or a non-demand pacemaker? What could happen?
R on T.
Yes. So that lovely R on T, where it spikes on the vulnerable part of the T wave and puts my patient into VTAC or VFib. If you look here, This half over here, I don't care if my pacemaker spikes. I don't care if my pacemaker spikes here. I don't really care if it spikes here, because this is the absolute refractory period where the heart can't accept another impulse, no matter how strong. But now it's sliding up the T wave and it's starting to get back to normal. So about halfway up your T wave, your absolute refractory period turns into your relative refractory period. And this is a time when your heart can accept a new piece of electricity, but it can often put your patient into VTAC or VFib. So not so nice. That's why we do not like to use non-demand pacemakers. If I had a pacemaker that had 4 letters in it, I would know that this is a permanent pacemaker. And this is a fancy pacemaker. And maybe I'm a young person and I want to be able to jog. A traditional pacemaker paces at a rate of 72. But maybe I'm young and I just have a crappy sinus node. But what if I want to jog? What if I want my heart rate to go up some? Then I want a rate responsive or a rate adaptive pacemaker. And oftentimes, this pacing unit can give you a heart rate of 130 because it senses that you're breathing faster and that you need more cardiac output. And cardiac output is heart rate times stroke volume. So it can increase your heart rate. Traditionally, what we see is anti-bradycardia pacing. Our patient's heart rate's low. We put in a pacemaker to fix them. But oftentimes we put in permanent pacemakers in patients. And if Grampy's going to sit there on the front porch in a chair, then he probably only needs a VVI device or a DDD device, but he doesn't need a rate responsive or a rate adaptive pacemaker, because the most activity he's going to get is go walk into the fridge, or he's mad because somebody put the remote in another room. But what about the 40-year-old who still wants to be athletic? You can't limit him to a heart rate of 72. Maybe he wants to have great bedroom activity. Well, I don't want a husband whose heart rate only goes to 72. I want him to ramp it up a little bit. So there's lots of reasons to put a rate responsive pacemaker in a patient. And then I can have the Cadillac of devices. I can have a DDD, so it paces in the atrium and ventricle. It senses in the atrium and ventricle. It will inhibit in both of those chambers if my heart rate is faster than the device is set at. But it can also ramp up and give me a big heart rate, so it's rate responsive. And maybe I have a low ejection fraction and I'm at risk for sudden cardiac death. I get a 5th letter, which means it's a defibrillator, internal cardioverter defibrillator. So devices are complex. I really simplified it here, but just know that temporary pacing will always have 3 letters. A permanent pacemaker can have 3, 4, or 5 letters. Okay, let's take a 10-minute break and come back at 3 o'clock, ready to go again. This is a lot of info. So see you in 10 minutes. Get some new caffeinated beverage.
Can we ask a couple questions first?
Absolutely.
How does a leadless pacemaker work?
Yeah. A leadless pacemaker is very complex. And I actually have a really good article. So there's criteria to have a leadless pacemaker. So the criteria is fairly stringent. It doesn't have much to do with cost. It's got to do with a lot of your comorbidities and some to do with anatomy. So I will send you that leadless pacemaker article. It's really good. It explains it. It's got some good pictures in it. Yeah.
And then are DDD and DDI essentially the same? And how are they different?
So a DDD pacemaker senses or paces in the ventricle and atrium, senses in the ventricle and atrium, will inhibit in both. In DDI, we turn atrial tracking off.
Oh,
So
that's where, yeah.
yeah. And so when somebody has a high sympathetic drive, like let's say somebody who has heart block, but their SA node wants to go fast, like they get excited, their SA node, the epinephrine gets released, the SA node gets excited. Well, if we kept that patient in a DDD mode all the time, then your ventricle would respond at whatever rate the atrium is happening. And so a lot of times, especially in early post-op patients, you don't want their heart to go that fast. And the reason why we put permanent DDI devices in patients is they're young. So young kids who naturally have a high sympathetic drive, their heart rate's fast, you don't want it to track every P wave. So you set it to only track at a rate of 80 or only track at a rate of 90. Yeah. Yeah, those are really good questions.
I think that was all of them.
Cool.
Oh, one more
Leadless
story.
Pacemakers are awesome, but I don't expect there will be questions on that.
Yeah, I think this is just more so for like my own benefit. So permanent pacemakers that are rate responsive, would their procedures take significantly longer than someone without, because they have to put like those sensors and stuff in?
Nope, it's all built into the device. You grab it off the shelf. Oh, this has rate responsive built into it. Cut the pocket, throw it in. Yeah.
Easy peasy.
Yeah, I say that.
If only it were that quick.
Yeah.
Yeah. If Dr. Dole and Dr. Wong were that quick, yeah. I just kind of minimized all their hard work.
Yeah. Okay.
Yeah.
Thank you.
No problem. Depending on how good of LV function you have, will determine how symptomatic you become. Yeah. Sorry, I forgot to turn the recording back on at last break, so we missed like 20 minutes of pacemaker stuff. Crap. Okay, so what you missed, if you're listening to this recording, is what DDD pacing is. There is a document that I will send out. And so now I'm going to stop my presentation and I'm actually going to share gonna share, nope, not that. I'm gonna share the Word document that I sent that has pacing. It says pacing exercise. Final review. Pacemaker activity, I guess is what it is. Okay, and everybody see this Word document up here? We're going to look at it and see if we need to fix anything as nurses. So here is my first picture. It's a paced beat, a paced beat, a paced beat, and then I go into sinus rhythm. Do I need to fix him?
No.
No.
No. This is a demand pacemaker. When I needed him, he kicked in. If you measure the pacing interval, so if you had a piece of paper, you could mark this spike in a straight line on the piece of paper and this spike. This is your pacing interval, the distance between two paced beats. And if you move that along, you would actually see that this beat right here came in before your pacing interval ended. So the device said, hey, I see a QRS. And if you had a temporary pacemaker in front of you, you could see that the pace light would be here, pace light here, pace light here, but then your sense light would be showing up over each of these QRSs because it's seeing what's happening here. So I don't have to see anything. Everything's good. Let's move on to, I want you to look at this one, and I want you to tell me what's happening.
Not sensing?
Yeah, it's pacing. Just trying to pace appropriately.
Pacing without sensing, right?
Do you need to turn your sensitivity up?
Yes. So his eyes are closed. We actually have this guy in a VOO mode. Uh-oh. The only time that we use a non-demand or an asynchronous pacemaker is when there is electrocautery, because a pacemaker is just told to look for electricity. Sometimes it can't discern between internal, intrinsic electricity or external electromagnetic interference. And so if you took a piece of paper and you marked out these spikes, you would see that they come in at absolutely regular intervals. And so this means your guy is driving with his eyes closed. I always think of a pacemaker as a car. Before you put your foot on the gas to make it work, you need to see where you're going. Because it would be pretty bad if I was driving like this. So I need to open my eyes, and then if I see a QRS, I put my brakes on. Hey, the heart's doing its own thing. I don't need to work. But then if I'm going too slow, I need to step on the gas and make the pacemaker work. So a VOO pacemaker is only ever used in the operating room when electrocautery is used, or somebody has forgotten to switch it off when they came out of the OR. And I bet you, Lamora, I think that's how I say your name, our young girl from Toronto, oftentimes the anesthetist is responsible for the pacemaker in the cardiac OR. And sometimes they forget to take it out of VOO mode and they bring it out to the ICU, and you just kind of roll your eyes and put it in the VVI mode. Yeah. So yeah, what I would do to this is switch it to VVI. I'm going to open his eyes so that he can see and sense appropriately. Tell me what I need to do to number 3 to fix him. Or do I need to fix him?
Turn up your voltage.
Yeah. So I'm not going to turn up my voltage, but I'm going to turn up my milliamps.
Milliamps. Yeah.
Yeah. So this is a dumb way how I remember it. I don't call it millivolts, I call it millivision. I know it's dumb. Physicians will look at me like I'm an idiot. Don't care. Millivision is my way of seeing. Smacking the heart has the letters MA in the middle of it. I smack my heart to make it work. So do you see how this is? Nice paced beats. And then all of a sudden I have a beat followed by no QRS. So the first thing you have to do when this happens is you have to determine, is this device sensing appropriately? And to do that, you need to know what your pacing interval is. Well, I'm going to show you a lazy way of doing it. I hate math. I can't do math. I fail math. That's why my bank account looks the way it does. I don't do math. But I do know some cheat ways of figuring things out. So I know that this pacemaker is working fine over on the left side of this page. So I take a sheet of paper and I mark the distance between 2 paced beats. And then I move that sheet of paper along and I see that this one came in at the right time, and this one, and this one, and this one, and this one, and this one. And then people say to me, but look at the long gap between here and here. I said, yes, but you have to remember the definition of a pacing interval. It is the distance between 2 paced beats, or the distance between a sensed beat and a paced beat. So this wide, weird looking rhythm is a ventricular escape beat. It's the ventricle saying, holy crap, man, nobody's doing anything. I better throw out a little bit of cardiac output here so my guy doesn't croak. It's great that the ventricle has the ability to do that. So the pacemaker said, hey, I see you and I sense you, and I reset my timer. And so the distance between here and here is the same as the distance between here and here. That is your pacing interval. So my first step is to make sure that my device senses okay. So I don't have to change its millivision at all. But I do have to increase my smack to cause it to capture. So if my milliamps were at 5 on a temporary pacemaker, I would go up to 6 or to 7 or to 8. The frustrating thing is if this happens in the middle of the night to a permanent pacemaker, I, as a registered nurse, don't have the ability to go get a programmer, put it on my patient, and increase the milliamps of a permanent pacemaker. So that would require that I get the physician involved. So a temporary pacemaker, I can simply go in and turn up the milliamps. If this were a permanent pacemaker, I would have to notify my physician and tell him that we had loss of capture. Everybody good with that one? Is this device sensing appropriately?
No.
And what did it cause?
Fib.
Yeah, so this is R on T. My QRS happened here. Here's my T wave, but a spike landed right here and put my patient into VFib. So I'm not playing with the pacemaker right now. I'm shocking my dude. Yeah. How do I fix this device? What's wrong with it? First step is to see if it's sensing appropriately. Do you think it saw this QRS?
No. No.
No. Do you think it saw this QRS?
No.
No. So the lower I go in numbers, the more sensitive I am. So if my millivolts are at 10, I'll bring it down to 9, to 8, to 7, to 6, so that I lower the fence so I can see more QRSs. And I may have to go all the way down to its lowest point. That's with a temporary pacemaker. A permanent pacemaker, again, has to be reprogrammed. And I can't do that as a registered nurse or without guidance from a physician. Do I need to fix this guy?
Like there's no P waves sometimes.
Yeah, and sometimes the P waves happen before the spike. Did it see that P wave?
More atrial sensitivity?
Yeah, so you need to lower your atrial sensitivity. What if it's at its lowest, which it usually is in temporary pacing?
You can switch the lead or switch your polarity.
Yes, so plain and simple, reverse the polarity. What you do is take the negative lead out of the negative slot and put it in the positive and the positive in the negative. Most of our temporary pacing wires now are bipolar, meaning they can act as a negative lead or the positive lead. And you need both in order to complete a pacemaker electrical circuit. But the electricity actually travels down and stimulates the myocardium through the negative lead. And so you can have another lead that's just tucked in under your skin. Sometimes we take a needle and poke it into our skin and use that as our, what we call a ground wire, or the wire that completes the circuit. But yes, this is not seeing the P waves that are happening, and it just be, so it could be in the AOO mode, or it may need the atrial sensitivity in the AAI mode lowered down. If it's as low as it'll go, then there's nothing you can do except reverse polarity. Try that.
Sue,
Yes.
if you reverse the polarity and there was no difference,
Then you just, so I don't get stressed about non-sensing in the atrium. what you will end up with is sometimes it will capture the atrium, sometimes it won't. Really isn't going to do any harm. Unlike the ventricle, if it doesn't sense appropriately, it can stimulate on a T wave. But because your atrial wire is only concerned with P waves, you're not going to get it to cause that R on T phenomena. So, yeah, good question.
I have a question, Sue.
Yeah.
Over time, like if this pacemaker kept on doing that, are you at risk of losing that atrial kick and then you're going to just have no P waves eventually?
Absolutely. Yep.
Okay.
Absolutely. Yep. And so oftentimes physicians will say, well, if you've done everything you can to enhance the sensitivity of that atrial lead, then maybe just put them into VVI pacing. Yeah, so you lose your atrial kick. Now, periodically, so in this second beat and this one at the last, I can see my spike in front of the P wave. So there actually is some atrial contraction followed by ventricular contraction. So there is some synchrony there. But yes, you're right. Lose my P wave, lose my atrial kick. Not much sense in doing dual chamber pacing if I can't pace my atrium. Yeah. What's happening here? First of all, I haven't told you what kind of pacemaker it is yet. And that's the most important thing. This is a VVI pacemaker. So my very first question is it sensing appropriately?
Yes.
Yes, it is. And so people often say to me, okay, well, this spike came in at the right time, it just didn't capture. Then I had an intrinsic beat, so my pacemaker would have said, oh, I sense this guy, and it reset its timer. So if you took a pen and you marked this beat and this beat on a piece of paper and you moved it, you would see that this one came in at the right time. Then if you took that same piece of paper and you put your first spike here, you would see that this spike happened at the right time. So it sensed this beat and it started its timer. And then it said, hey, I'm going to stimulate the heart. Just didn't have enough juice to do that. But then people get really stressed about this one. They say, well, that didn't sense. Actually, it did. And the reason why I know that is, let me just erase this stuff. The reason I know that is because it's a VVI pacemaker. It's not sensing P waves. It doesn't see P waves. So it was time for the ventricle to be stimulated. So the pacemaker kicked in. It just coincidentally happened at the same time the atria was causing a contraction. And so I need to increase my milliamps for this patient to enhance the capture, because sensing is just fine. Does that make sense? Pacing is hard. And then we did the four phases of DDD pacing. So good job. That was well done. Okay. Screen, stop sharing. Okay. Is anybody dying yet? You must be getting close. I'll take you right to the cliff, but I won't push you over, okay? So how about we take, we're gonna go till 4:30, as far as we get to 4:30. Does anybody want to break right now? Don't be shy, just let me know.
I'm good.
Good, okay. Oops. Let me just close my door here. Okay, so here are some hemodynamic numbers that I think you should know. So a mean arterial pressure is normal when it's above 60. So that feeds your head, your heart, your kidneys, and all of the good organs. When it's below 60, we have significant risk of ischemia, and our body switches from, let me just, sorry, open up the curtains here. When you don't feed your body enough oxygen, it switches from aerobic metabolism to anaerobic metabolism. And so that's great that our cells are able to maintain that ability to feed themselves. However, the breakdown of anaerobic metabolism is lactic acid, and our body does not like to be acidotic. So having a blood pressure below 60 leads to ischemia, which leads to the buildup of lactic acid, which can really play havoc with everything. Our heart hates to be acidotic, hates it. So I think you should also know what a normal preload and afterload are. So when you think of preload, I want you to think of how full of volume. And when I think of my right heart preload, I think of something called a central venous pressure. Normal is 2 to 6 according to textbook. However, some people say 2 to 10. So if they gave you an abnormal parameter, it's going to be he had a CVP of 14 or 16. It's going to be quite out of range. When I look at volume in the left heart, I look at my wedge and I measure this with a pulmonary artery catheter, and it's 6 to 12, although we're happy if it's basically below 16-ish. But please know that a left heart preload, also called a wedge, is the same as what we measure on a cath, LVEDP, left ventricular end diastolic pressure. So my patient is volume overloaded when I have a wedge of 18 or 20. So my patient is volume depleted when they have a wedge of 4, 3. And so we'll talk about how we manage too low of a preload or too high of a preload in just a minute. The blood pressure in your pulmonary system, your systolic, your pulmonary artery systolic is 15 to 30, and your diastolic is 5 to 15. Now you may use a few different numbers in your facility, but these come from Edwards Life Science, and this is kind of the it is the reference that we use for the CNA exam. So this is where we get the numbers. Just know that your facility might use a little bit different. When we think of afterload, I want you to think of the resistance or the blood pressure in the blood vessels where a ventricle is ejecting into. When you think about right heart, your right heart pushes out into the pulmonary system. When you think about your left heart, it's called your systemic vascular resistance, or your SVR, and that is how much resistance there is to left ventricular ejection. And we measure it in this very strange units of measurement. It's called dynes per second to centimeter minus 5. You do not need to know those exact numbers. But if a question said you have a high SVR, then that means that there is a high resistance. Your ventricle has to work harder to eject its contents. Or if your patient had a low SVR, that means their blood vessels are quite vasodilated, and maybe you need to add a vasopressor. And then cardiac output, 4 to 8 or 6 to 8 liters, depending on the reference you might use. But more importantly is cardiac index. Index takes into account your patient's height and weight, and then adjust that to your cardiac output. So cardiac index of 2.5 to 4 is a textbook normal. A lot of times they will accept 2.2 to 4 liters per minute per meter squared. But just know that when you have a low cardiac index, your patient is symptomatic. And we're going to go through a couple of cases here quickly. So there's a quick recipe. When your patient has inadequate cardiac output, no matter where they are, in a clinic, an intensive care unit, or at the Walmart, when somebody passes out or somebody looks symptomatic, you should immediately think, oh, they look bad. And that should translate into they have inadequate cardiac output. And one of 4 things is always wrong with the person. Doesn't matter whether they're in a GI clinic, they're at the dentist, or they're in a cardiac ICU. There are 4 determinants of cardiac output: heart rate, preload, afterload, and contractility. So if you took the equation, sorry, I thought I had the equation in there. Oh yes, right here. Cardiac output equals heart rate times stroke volume. Stroke volume is made up of preload, afterload, and contractility. So when I break that equation down, it gives me 4 determinants of cardiac output. And so whenever my patient looks bad, whenever they're symptomatic, there is a quick little recipe that I go through. And I look and I say, is it heart rate or rhythm? Is it preload? Is it afterload? Or is it contractility? And my recipe is always in this order. I look at my heart rate and rhythm first. Then I look at preload, afterload, and contractility. So let's say we go into Grampy's bedroom. He's in a coronary care unit. And I look at him and I say, oh, Gramps, are you doing all right? He's kind of diaphoretic. And I go over to talk to him. He's cool and clammy. So I assess that he has inadequate cardiac output. I'm going to do a set of vitals. The first thing I'm going to say is his heart rate too high or too low? So if it's too high, I know that my filling and feeding are impacted. So there's 2 4-letter F words that happen in diastole. Whenever I have a rapid heart rate, that affects my diastolic filling time. So how do I assess this? If I have too little preload, I'm going to listen to my heart sounds. I'm going to listen to my lung sounds, my intake and output. I'm going to determine if he's thirsty. What's his weight? What's his skin turgor? What's his jugular venous distension like, or are his jugular veins flat? Do I have a positive hepatojugular reflex where I push in on my liver when a patient's sitting at about 30 degrees? And do I see fluid movement in his jugulars. That means his liver's engorged because there is no valve sitting between the liver and my jugular vein. So what's his chest x-ray look like? What's his IV rate going at? And finally, do I have a CVP and or a wedge to add to my assessment? So if I have too little preload, then I'm going to have a negative fluid balance, no weight gain, all of the things that tell me I don't have enough volume. So I think I kind of went too fast. Heart rate, I correct it, whether it's too high or too low. The key to remembering heart rate is sinus tach is always a symptom of something. And so you don't treat sinus tach with metoprolol. You treat it looking at the cause. If my heart rate is too low and I think that my heart rate is too low and causing my inadequate cardiac output, then I'll either give atropine or I will pace him. Sorry about going too fast. So I look at my heart rate and rhythm. So let's say I look at Grampy in the bed and he looks bad, but I check out his heart rate and it's 102 sinus tach. Well, I think his sinus tach is a symptom of something. So I'm going to go on and I'm going to assess preload. We just went over too little preload, too much preload. I'm going to do the same assessment. So my heart sounds, my lung sounds, my intake and output, my weight. And I know weight is not sexy. Nobody likes to weigh patients. It's a pain in the butt because then they got to pee and all that stuff. However, weight is one of the best indicators of volume status. Maybe my patient's too ill. Make sure you weigh them when they come into your unit so that you can assess that every day. And so if my patient is volume overloaded, then I'm going to have a positive fluid balance. I'm going to have a weight gain. I'm going to have a positive hepatojugular reflex. And I'll have an increased CVP or wedge. So how do I manage preload issues? If my preload is too small, then I'm going to give fluid. If my preload is too much, I'm going to give diuretics. How would vasodilators like nitroglycerin help with volume overload? How could we make our preload patient?
Your volume's almost like dispersed a little more because you're vasodilated.
Yep. I keep more fluid in the periphery and less going back to the heart. Yep. So I've just displaced the volume. I haven't taken it away. I've just displaced it. Yeah, good job. Okay, so let's say I look at Grampy and I say, oh, I think your volume overloaded, but your blood pressure's too low. I'd like to give you a diuretic, but your blood pressure is 80/40, and if I gave you 60 or 80 of Lasix, I'll probably kill you. So whenever you look at preload, you also have to look at afterload. So afterload basically is your blood pressure. If you didn't have a pulmonary artery catheter to give you the vascular resistance, you're really looking at blood pressure. Your blood pressure is too low, then we need to give you a vasopressor. Your blood pressure is too high, then we give you an anti-hypertensive or a vasodilator. So we always look at preload first. And if we think that low preload is the problem because the blood pressure is too low, then we will give volume. But if you have adequately volume resuscitated a patient and you still have low blood pressure, then you need to add a vasopressor. We have a couple of them. The number one choice in cardiogenic shock, according to the emergency room physicians, the Canadian Cardiovascular Society, and the angioplasty and interventional radiologists, is norepinephrine. That is the frontline vasopressor once you have managed your patient's volume. It says dopamine to the rescue. No. So I'm really hoping that they have looked at the exam and removed dopamine for everything except a patient who's in an emergency room situation who has low heart rate and low blood pressure, and they're waiting to put in a pacemaker. That's really the only indication for high dose dopamine left anymore. Then you could use combination drugs like vasopressin or epinephrine, which are both vasopressor and positive inotropic drugs. So fix your blood pressure. Frontline drug is Levophed, but you have to make sure you have volume loaded your patient before you add vasopressors. Can anybody tell me how having too high an afterload could put the patient into acute decompensation? So let's say you have critical aortic stenosis. How could a TAVI fix your afterload? TAVR.
Less pressure in the left ventricle.
Yeah. So my aorta is fine. There's nothing wrong with the pressure, but the door to get into the aorta is only open a little tiny bit. And it's kind of like a tap when you turn on to get a drink of water. There is more pressure in the tap if the valve is only halfway open than if you open it wide open. Or I often think of aortic stenosis as, and every Canadian can understand this. Let's say you have a screen door on your house. It opens out. You've gotten 6 feet of snow, and now you want to get out your front door. So you have to push and push and push to get out your front door. Well, that's kind of what your left ventricle has to do to overcome critical aortic stenosis. So by fixing a TAVI, you can actually fix the patient's cardiac index by allowing the left ventricle to do its job and kick out its contents. So afterload is about blood pressure. Not enough. You need to make sure he's adequately volume loaded first, and then norepinephrine would be your drug of choice. If your afterload is too high, then maybe you need to just give a vasopressor. Maybe your patient is in a hypertensive crisis. But if it is aortic stenosis, then you might need to see if this patient is a candidate for a SAVR, a surgical aortic valve implantation, or a TAVR, transcatheter aortic valve implantation. So I always think of critical aortic stenosis as Gus, the fat-butted mouse, trying to squeeze into the mouse hole. Or I like this analogy of trying to open this screen door against 6 feet of snow. That's kind of what the left ventricle has to do. So let's say I checked out Grampy. I looked at his heart rate and rhythm and said, oh, he's sinus tach, that's a symptom. I looked at his preload and I said, he's probably got too much volume, but he has a low afterload. So I don't want to give him a diuretic. And I start my vasopressor and I bring my blood pressure up. But now I think, does he need a diuretic? Or if I made his heart pump more efficiently, would his body be able to rid itself of that volume? And so oftentimes when we think, geez, I'm not sure that too much volume is his problem. I think too much volume in his heart is the problem. Then I'm going to say, well, maybe I need to add a contractility agent. So there's 4 things in my recipe: heart rate, preload, afterload, and contractility. And so by the process of elimination, I've worked my way down to the 4th ingredient. And if I have a low stroke volume, so let's say here's a healthy 70-year-old guy, the average stroke volume is 70 mils. How do we get an ejection fraction? Well, we take the stroke volume and then we take the numeric value of our end diastolic volume or end diastolic pressure. So that is our wedge. And we divide the 120 into 70, and we get 0.58, which is 58% as his ejection fraction. I want you to do the math and type it in the text box. If your stroke volume is 70 mils, but your end diastolic volume is 180 mils. So you might have to dig out your phone with your calculator on it. I know I do. So your end diastolic volume is 180 mils. What did you get for an ejection fraction? Our stroke volume didn't change. Oh, my chat box left me. Darn. Sometimes when I click it too fast, it leaves. Anybody able to do that math? You no longer have an ejection fraction of 58%. Can anybody come on to the mic? Because my chat box has disappeared.
39.
Perfect. So big difference. I now have a systolic heart failure situation. My ejection fraction is less than 40%. In today's world, we would call that HFrEF, reduced ejection fraction. For purposes of the exam, we will call it systolic heart failure. So we calculate the ejection fraction on either cardiac cath or an echo. And when it is low, when we have low contractility, then we need to add a positive inotropic drug. And the true inotropes are dobutamine and milrinone. But we can also use epinephrine and dopamine because they have both vasopressor and positive inotropic effects. You would never start epinephrine as your frontline drug. It's just too strong. It's kind of like killing a fly with a grenade when all you need is a little fly swatter. So we never start out with giving epinephrine unless your patient is in anaphylactic shock, of course, but it would never be the very first drug that you would give. You would probably have a little bit of norepinephrine, also known as Levophed, to increase your afterload. And then we might add dobutamine or milrinone. Dobutamine will cause an increase in heart rate quite significantly and much more so than milrinone. But both epi and dopamine will cause a significant jump in heart rate. Oh, this is heavy stuff. Okay, let me see a couple of faces, because that's the only way that I can tell if I pushed you over the cliff. Yeah, you're hanging. You're hanging by a branch. Okay, let's do a couple of case studies and then we'll call it quits. Okay, so got this little recipe. Only 4 ingredients. If you screw them up, you're going to kill your guy. Really, you will. And so sometimes you will have to guide the resident. Say, oh, sorry, buddy. I know you want to get rid of all that excess volume. I know his preload's too high, but I'm not giving 80 of Lasix when his blood pressure is 72 on 50. Yeah, you can't do that to him. So there's a dude, his name is Jack. He's 72 years old. He is in the intensive care unit and he is diagnosed with sepsis from a leg infection. So we actually had one of these patients in CCU last week. He didn't have a leg infection, but he was in septic shock. So when I first look at Jack, I look at his heart rate and his blood pressure. Is anybody stressed by his heart rate and his blood pressure? His heart rate's, I don't know, 130-ish.
Yeah, I'd keep an eye on that heart rate, but
Yeah. So I'm like, yeah, okay. So if I called my doc with that, probably wouldn't receive any orders. But look what happens when I go lay my eyes on Jack. So first of all, he's 72, but he looks like 92. He's got dilated pupils, he's cyanotic, he's got dyspnea, orthopnea, crackles, he has a cough and a wheeze, his blood pressure's 100 on 59, he's got nausea and vomiting, ascites, dependent pitting edema, he's anxious, his SATs are falling, he's confused, he's got JBD, he's fatigued, he's got an S3, he's got an enlarged liver and spleen, he's not peeing, and he's cold and wet. Quite a different picture than what 2 vital signs have told me. What this tells you is you have to lay your eyes on people. And so I think Jack's kind of a hurtin' honey. And so I would like you to type into the chat box what you think the problem is and how you'd like to fix it. So there's only 1 or 2 problems that can ever happen. And sometimes things happen together. It could be like heart rate and preload or preload and afterload. But there's only 4 things that can go wrong with any patient. So Jack's septic. He didn't come in with cardiac problems. He came in with sepsis. So, anybody think it's heart rate? Do I want to give beta blockers?
I kind of want to give fluid for the heart rate.
Yeah, so I look at my heart rate, and I'm like, you know what? I think my heart rate is a symptom of how sick he is. And so I think preload is this guy's problem. Everything here leads me to think that Jack is at home with heart failure. You don't develop ICDs overnight. You don't develop pitting edema. Well, sometimes we do when we travel, but all of these things have happened because Jack is in heart failure. But the thing that threw us off is that he came in with sepsis. And septic patients often require a lot of fluid. Do you want to give Jack fluid? No, I don't want to give him dobutamine because I don't know about his contractility yet. He's wet. I don't want to give him a beta blocker. I don't want to give him a fluid bolus because I think he has too much. I actually want to give him a diuretic. And I think I can because my blood pressure is 100/59. So I actually get Jack to pee 1.5 liters. His blood pressure drops a little bit. But I fixed him by just looking at one parameter. Okay, case 2, 48-year-old female, complaints of shortness of breath, lightheadedness. Her blood pressure is 84/50. Her chest is clear, no S3, a negative fluid balance, collapsed neck vein. She appears very dry. Here is her rhythm. What do you think's wrong with her and how do you want to fix it? And the slide says maybe there's more than one treatment.
Not enough preload. We think preload.
So,
Not enough.
so that's good thinking. So I actually think it's both. Heart rate and rhythm. So you see she's in a heart block here, 2nd degree type 2. My PR is constant. Heart rate is fairly low, but she's super dry. So a fluid bolus certainly sounds like an option. Maybe atropine could work in this patient, but definitely a pacemaker. I don't think I need a Levophed infusion yet because she's volume depleted. I need to fill the tank before I start a vasopressor. And I have no indication that she needs any contractility agent. So I fixed her by fixing her heart rate and her preload. She had a combination of both. Which came first? I don't know. She probably started with the rhythm and then didn't feel well and didn't drink. Who knows? Okay, let's do one more case and then we'll be done. So how about, I'm tired of talking. How about Bria and Jesse? Tell us about case number 3. Tell us about Joan.
You want me to read it?
Sure.
Okay. So Jones, an 86-year-old female who arrives to the ER in AFib, rate of 68. Her blood pressure is 106/50. Lungs sound wet, and she has some peripheral edema. She has S3 with a new, very loud, grade 5 systolic murmur, best heard in the 2nd intercostal space, right sternal border that radiates to the neck. Your turn.
Oh, that was good. With as much enthusiasm as Bria.
I'm long-winded.
She is on Lasix 40 milligrams twice a day, warfarin 2 milligrams daily, metoprolol 25 milligrams BID, Crestor 10 milligrams daily, Ramipril 5 milligrams daily, and daily aspirin 81 milligrams.
Perfect. Thank you, ladies. Okay, so what are some of the things that I'm going to highlight on this case?
Her AFib.
Absolutely.
Her S3 with wet lungs.
Yeah, so AFib. She's wet.
Her edema.
Edema.
The new loud murmur.
Yes. So, I want you to think about this patient, where you're putting your stethoscope, and I want you to type into the box. Sorry. What you think her problem is, how are you going to fix it? So one of the 4 issues, heart rate, preload, afterload of contractility. So here she is, a new grade 5 systolic murmur. So Sasmar and Dharma should be going through your brain. And I hear it, the second intercostal space, right sternal border. There's only one area that I listen to heart sounds on the right. Who thinks atrial fib's her problem?
Nope, that's chronic.
Ah, awesome. Because she takes warfarin. I know that her atrial fib is chronic and her heart rate, ventricular response is only 68. So do you see how in the stem of that question you were able to make assumptions that it's not new onset atrial fib? Heart rate's only 68. So I've gotten rid of heart rate and rhythm as a problem.
That's her aortic valve.
It is her aortic valve. The damn thing won't open.
Yeah.
Yeah. So when I look at systolic murmur, I have SASMR, ASMR. Well, I'm going to hear mitral regurg down here in my mitral area. I'm going to hear aortic stenosis up here in my aortic area. How come she has all this extra preload? Because the blood can't get out of the heart because the door won't open. So preload is a problem, but if I get an IV diuretic into her, potentially that could be a symptom treatment, but ultimately this lady needs either a TAVI or an aortic valve replacement. Critical aortic stenosis is her diagnosis. Do I need amiodarone to convert the rhythm? God knows, she's probably already had that at a previous admission. I don't need any contractility agents. I definitely don't need a fluid bolus, but I may give a diuretic and consult her for a procedure. So guys, I know we didn't get to the end. What did we have left? We had the summary of how do we manage cardiac output, first heart rate or rhythm, and this just gives a summary of what we just did here. And cardiac surgery, the slide that I want you to pay attention to, so you can watch some of these YouTube videos to give you an idea if you don't have surgery at your facility, give you an idea of what happens in the OR. This is this slide. Where is it? Diseases of the aorta. I think most of the girls who work at the Heart Center have seen this. It's a 16-minute video on a type A aortic dissection. It's one of my favorite videos. Just gives you an idea of how they fix a type A aortic dissection. But pay a little bit of attention to the complications of cardiac surgery. I remember a specific question about Beck's triad. But what I want you to look at are the nursing sensitive patient outcomes related to surgery. These are just some random things. Pain control and ambulation are what are required to limit pulmonary complications. Managing your pre and post hemoglobin A1C will decrease your risk of wound infection. So hemoglobin A1C less than 7 is super important. When your patient has unexplained metabolic acidosis in the post-op period, think ischemic gut. Rapid defibrillation is especially important in this patient population because acidosis is so poorly tolerated. Aortic and mitral valvular surgeries are common cause of heart block, ventricular standstill, and asystole. That is the reason why we put pacing, ventricular pacing wires in patients that we can actually get into their heart. So most sternotomies, most minimally invasive patients, we can get ventricular wires sewn to them. So I want you to think specifically when you're talking about cardiac surgery, think of the nursing sensitive patient outcomes. Meaning, what do I do as a nurse that helps or hinders a patient? Those will be the questions, not, you know, up here, what are the indications for cardiac surgery? Triple vessel disease, left main disease still remain the common reasons why people have cardiac surgery. We now do high-risk PCIs for some patients that are not surgical candidates, but we use a syntax score. It's a special score that determines severity of the cardiovascular disease to whether they should have PCI or whether they should have surgery. And that, guys, brings us to the end of a very long afternoon. Some of you are still just arriving on noon hour out on the West Coast. So hopefully you still don't have a whole day of work in front of you. But I want to thank you for your attention, and I will certainly stay on if you have any questions or comments. So thank you for your attention, and it's my absolute pleasure to kind of help mentor you along. And I just want to say how super proud I am of each of you for having the courage to step up. I really want you to send me a note and tell me when you're writing. And if you would like, tell me whether you were successful or unsuccessful. I do not expect any unsuccessfuls. But do not be shy or embarrassed, because I forget who it was. Michelle, it might have been you. Did you send me the comment in email last week?
I did, yes.
So do you want to share that story? Because this is what it's all about. It just made me so excited and happy.
Sure. So I've been doing most of my readings on night shift. And so last week it was the carditis topic, basically. And so I had printed off all of them and started reading them on my night shift. And I was actually orienting somebody to the unit. So they took basically all the patient load. And so I had some extra time to go through all of the readings. So I did that. And so I was learning about endocarditis and pericarditis. And on that shift, I actually happened to have 2 patients that were being worked up. One was being worked up for endocarditis, and he had a congenital heart defect. So that was the rationale for him being in there. And then there is another patient who he was being worked up for possible pericarditis with chest pain not yet diagnosed. And what I didn't know at the time was that he had the echo earlier that day, and it was inconclusive for whether it was pericarditis or not. So after reading the one paper that you had sent us, where it gave like a really nice picture of what it would look like on the rhythm strip at 2330, we always print our strips, and I happened to look at it, and I was able to see that there was the chronic ST elevation with the concave look to that depression as well. So previously, what I forgot to say was that the patient had come in the day before and they thought that it was a STEMI. However, he had chronic ST elevation. So then that's why they were querying the possible pericarditis at that time, but nothing had been conclusive up until that point. And so the resident happens to be on the unit at the time. So I took my hypothesis to her and said, like, what do you think of this? And she's like, well, let's go have a look at what his EKG shows. And so I went back to his file, and I realized that there was actually a different patient that was actually in his file. And so we didn't even have a baseline EKG at that point for that patient. And so because of this and what I had found, we ended up ordering a stat EKG so that we could see if we could actually prove this rhythm moving forward.
So I know that passing the exam is what it's all about for you. For me, it's all about your ability to take what you